Dr. Jillian has been so kind to agree to speak to us. And Dr. Jillian is a physician here in town, specializing in hormone therapy, and she has a very lively practice. And right now, you're not taking any more patients, but so she can't be your primary health provider, but she can work with you as a consultant on medical transition goals, and she does work with quite a few people who are transitioning.
Yes.
And Dr. Jillian will give us the medical perspective to layer upon the neurological. And then following her presentation, we will have a cute question and answer for all of this. Following that, we will pass out survey sheets, because we want your feedback, and whatever questions we forgot to ask, you please answer and tell us what questions you wanted answered. And that'll be our day. So now we have Dr. Jillian. Thank you.
Thank you, Bev. Thanks, everyone. This microphone that I'm wearing, can you hear it? It's for that.
Yeah.
Okay, so I get to use both. All right, can you hear me okay at the back? Yes. All right. I haven't timed this presentation, so if I run late, just give me the hook. And if I finish early, that means we have more time for questions. And really, you can't cover menopause in 2 30-minute sessions. Like, I could talk about this for days. So I'm hoping that this is just sparking conversations between you and your community, but also like between you and your primary care provider. Hopefully everybody has one. I know because it's Lethbridge, you don't all have one. There's a significant number of us that don't have good access to primary care, and that's something that really needs to improve. But for those who do, we have a pathway, and I'm going to talk a little bit about that briefly, but something that's been developed provincially by a whole team to try and help primary care providers who don't do this as much yet to feel comfortable engaging in talks around management of perimenopause and menopause symptoms, so that everyone who has care can have their providers get like what's the latest and greatest and recommended approach. So menopause. What you haven't been told? Question mark. Because as we'll see, I don't actually know what you haven't been told. So my disclosures are pretty simple. I haven't received any industry funding, no fees from any drug company. I did get paid from Primary Care Alberta for time working on the co-design team for the provincial pathway. And also Friends of Medicare gave me this opportunity to talk to you and also bought my brunch ticket. So thanks very much, Bev and Friends of Medicare. My biggest disclosure, I don't know what you don't know, but hopefully it's pretty similar to what I didn't know and what my sister didn't know and what my patients wish they had known. And so that's what I tailored my talk around. I'm sure in the question period, you can fill us in on anything I missed. A little bit about me. I'm 48. Guess what's happening? Just last week, as I was getting ready for this presentation, much to my chagrin, I am a settler descendant. That colors my perspective on things. And also, research shows my perception of symptoms is going to be partly coded by my social environment, but also partly by my genetic background. I am heterosexual, cisgender, and trained in Western medicine. I know there are many different ways of knowing that are valid and important. This is the one I know about. So you can ask me all kinds of questions, and some of them are going to be within my wheelhouse and skill set to answer, and some I won't be. And I'm a family doctor. And I don't know if I would call myself specialized in hormone prescribing. I do it a lot. It started out mainly with trans individuals who are younger, not yet at perimenopausal age for the most part when they start seeing me, but kind of morphed into, at the time, I was the only female family physician in Tabor, and so I ended up seeing a lot of patients of my colleagues who had questions about menopausal transition. And a bit about inclusive language. So in the presentation, but also just in my general speaking, I'm not going to assume everyone who goes through menopause identifies as a woman. Likewise, not all people who identify as women will have gone through a menopause. Trans women might continue their hormone therapy for life, and so can cisgender women going through menopausal treatment. Yeah, so want to include everybody who might experience estrogen and then not having estrogen, or having estrogen that is added back. There is a clinical pathway, so this is accessible online. Anyone can read it, but it's really the language, the resources is targeting physicians, nurse practitioners, primary healthcare providers. It's a 2-page algorithm. All the other provincial pathways are 1-pagers. Menopause involves a lot. It's like a 48-page document altogether. But we also have, so you can direct your doctor or nurse practitioner towards it if you've got questions about menopausal care that they can't answer yet. And there's also a patient pathway. And don't get mistaken. There's like a 1-page summary that just talks about like holistic health and talk to your healthcare provider. But then if you click the little link at the top right corner, the patient information is also like 30-something pages. There's a lot there. Don't try to digest it all in one sitting. But those of us on the team that designed it were really pleased with what came out, and we hope that you use it and that you give us feedback on it, because it's only been live less than a year now, and so we do want to make it as good a tool as possible for everybody. Okay, when we say menopause, we're really talking about the period of perimenopausal transition and then everything that comes afterwards. So instead of saying perimenopause and menopause every time, I might shorten it to menopause. This is when the symptoms start, perimenopause. It can, as Robin told us, last 7 to 10 years, although some people's symptoms will continue forever. It can start in your 30s or your 40s. Not an uncommon thing. So that's one of the things that my sister said really surprised her, was at 47 when she started having her hot flushes. And irregular cycle is often the initial symptom people might express, but those of us who have hormonal IUDs, people who don't have periods for other reasons, someone who might have had a hysterectomy, they won't be able to track it by bleeding changes. So lucky for us, there are lots of other symptoms that can happen. So you've heard about hot flushes, or some people call them hot flashes. When I hear flash, I always picture like a flashing red light, and that is definitely not how my lava dips feel. So I like the hot flushes term. Yeah, brief but intense, that's what I get. Night sweats is another vasomotor symptom. Similar to hot flushes, we're talking about wake up covered in sweat, maybe need to change your night clothes or the linens if you're ambitious. Vaginal dryness or pain. And unlike the other symptoms, this one, if you don't treat or replace, this is going to continue for the rest of our lives. We'll get into that more later, because it's one of the ones I love talking about. Oh, but there are so many other symptoms. And you can have sexual concerns, changes in your menstrual cycle length, mood change, sleep change. Robin gave us a pretty good rundown of everything. Some family groups, some cultures or races, no, there's not different races of people. I don't know the term. In some areas of the world, women report more joint pain than any hot flush or other vasomotor symptom. Sometimes it's called musculoskeletal syndrome of menopause. So that was a new one I learned this last year. Bladder issues or incontinence are not a normal part of aging. They are a common symptom of menopause. Cognitive changes, as Robin gave us, weight gain, frequent or tendency to urinary tract infections, bacterial vaginosis, and ultimately the end of the menstrual cycle. And then 12 months after your final menstrual period, that's the official start of menopause, which is all those same symptoms as before, just no more bleeding. And that continues for the rest of our lives with a life expectancy of 83 years. That's a lot of years of symptoms. But there are treatments and management strategies available. Okay. I get asked a lot, should we test my hormones? I think I might be perimenopausal, or I think I might be having some menopause or hormone changes. The diagnosis of perimenopause and menopause is clinical, which means if you're in the right age group and having any of these symptoms, in particular, if you're having period changes, that's very helpful. If it sounds like perimenopause, it's perimenopause. And of course, you can do investigations to make sure there's not something else going on, especially if the situation is a bit of a puzzle, or if there are symptoms that aren't already on that very long list of possible symptoms. Fatigue, joint pain can happen for lots of reasons, let's be honest, but if it happens at the time that you're also having hot flushes or vaginal changes, and your periods are getting a little irregular, often you don't have to go looking any deeper. So the diagnosis is clinical, except if you're younger than age 45, when you start having long gaps between period cycles. And age less than 40 always needs to be investigated for another cause for your symptoms. Between 40 and 45, any 4 months without a period should be investigated. Unless you've got a reason not to have a period. If you just had your Depo-Provera injection started or had a hormonal IUD in, then that would explain why you're not getting your periods anymore. Also, in perimenopause, there's still the possibility of pregnancy. So everybody having a missed period in this age group definitely should be tested for pregnancy. All right. I am not sure why that one showed up last. Jillian, unlike Robin, I am not a professional presenter and teacher of people. Most of my conversations happen one-on-one. This turnout is amazing, and let's face it, a little bit intimidating. Okay, menopause. Again, if it's been more than 12 months since your final menstrual period,
Just went off.
It's, yeah, you need a new battery or a new mic?
Is there another microphone?
Yeah, there's one right there.
can you hear me?
I'll turn it off.
Thanks.
Is that mic two?
Yep, that's mic 2.
Mic 2, yeah, it's on, but it's,
They have to turn it on.
Sorry.
hang on, more
It's
technicality.
your electric personality.
It must be my electric personality. It's a funny thing you say that. I worked in a jewelry store one summer before med school, and I had to change my watch battery on my Ironman watch every 3 days because it kept junking out on me. And so I always said it was because of my electric personality. That Jillian, she's a quirky one. Okay, menopause usually will happen between ages 45 and 55. It's not unexpected for it to happen at those times. And like Robin told us, with a life expectancy of 83 years, half of all people in Canada are going to get to spend 30 to 40 years in menopause. So this is an area that should be studied and funded better. There should be more access to supports and healthcare. Yep.
Speakers went off at the back here when you changed mics.
Oh, shoot. Stay tuned for more. There's huge profit to be made off of this. It should be better funded and better supported.
How we doing?
Can you hear me now back there? We're good. Okay.
Okay, thank you.
Thanks, Andrea.
Thanks for letting us know. And thank you, Andrea, for your IT work. Good Lord. Because because I can't yell at you for half an hour. Should be better funded, better researched, thanks to our researchers who are doing the work on it. But drug companies should be chomping at the bit to develop novel approaches. And let's face it, they're working on it. Okay, menopausal hormone therapy. People often come in asking for HRT, and I keep trying to change the framing. We're calling it MHT. There's a couple of reasons around it. Language matters because it frames how we think about things. So we're not replacing estrogen. That's what hormone replacement therapy was signifying. It's not something that is meant to be there. Perimenopause and menopause are a natural process. It's normal for the ovaries to stop producing estrogen, but normal doesn't always mean comfortable or good for you. And so when we use estrogen or other treatments, we're doing menopausal hormone therapy to manage symptoms or risks, and we call it MHT. Other language changes that's going to come up later, we used to call changes in the genital tract, in the urinary tract, vulvovaginal atrophy or atrophic vaginitis. I know, I hate that term. I hate it more now that we have genitourinary syndrome of menopause, or GSM. So basically changes that happen if you withdraw estrogen from the tissues lining those tracts are manageable, treatable, adjustable, and atrophy just sounds kind of accusatory to me now. Okay, off we go. Estrogen. There's a number of different ways to give or take estrogen. The one we use most commonly now is 17-beta estradiol, and this is identical to the form that the human ovary makes. Often in the prescription, it'll just read estradiol. There are also forms that are conjugated estrogens, used to be conjugated equine estrogens from the urine of pregnant mares, and that had a number of different forms of estrogen. There's one vaginal cream that's estrone, yeah, a different form of estrogen. And we can give it in oral tablets, in a gel you apply to the skin daily, in a patch that you wear for half a week or a whole week, depending on the patch formula, creams that are inserted vaginally, or vaginal tablets. There's now an ovule, which is like a tablet, but kind of softer and contains coconut oil and palm oil. Or when it's not on back order, there's a ring that can be worn in the vagina for 3 months at a time that just slowly releases estrogen to the local tissues. So many ways to take it. And in Canada, we have indications for use of estrogen for the following. It's indicated for treatment of vasomotor symptoms, so that's your hot flushes and night sweats. Genitourinary symptoms like bladder urgency, vaginal dryness, discomfort with intercourse, itching, burning, a thin watery discharge that can be irritating, and maintaining bone density if you're also having other symptoms of perimenopause and menopause. So basically, if you're going to take hormone therapy and also wanting to reduce your risk for osteoporosis, then it's an indication. Now that's a short list compared to all of those symptoms that you saw perimenopause and menopause can involve. And so what about those things? Well, so you can try and treat those with hormone therapy. You might have success, you might not. It's not something that is prohibited from talking about. And like with many things in medicine, there are on-label uses for treatments, and there are ones that are called off-label. Basically, when the medications went to market in Canada, they were approved for use for these things. We use lots of things off-label. in Canada and around the world. Someday we might find out that estrogen treatments are helpful for the cognitive symptoms of menopause and the mood symptoms and other symptoms, the weight gain or what have you. But for now, these are the official indications. And what I didn't know about menopause, or what we thought we knew about menopause, has really changed a lot in my 22 years in practice. So before the Women's Health Initiative, it was taught that estrogen is good for your heart. Everyone should be on estrogen. And then the WHI came out, and there was this mass panic and a huge media campaign, and estrogen is bad for the heart. Everyone got their estrogen pulled away. It caused a lot of grief and symptoms and uproar. And now we know estrogen is helpful for many things. It may be risky for your heart if started at the wrong time or in the wrong patient. It may be beneficial for your health, maybe your heart health, maybe other things, maybe dementia risk. It turns out it's not black and white. And what we shouldn't do is go and pull everybody's medication just because some study was published somewhere and the media made a big noise about it, right? We should have these individualized conversations between women and our care providers and figure out what is the right balance for you. Okay, estrogen needs progesterone if you have a uterus. You should not take just estrogen if you still have your uterus or haven't had a hysterectomy. And the reason is because just estrogen or unopposed estrogen causes buildup of the endometrium, the lining of the uterus, which can grow into endometrial cancer. So, estrogen for many patients requires use of a progesterone. And there's a lot of ways that can be given too. There's a pill, usually micronized progesterone or prometrium. And as Robin mentioned, it can have other potential effects that might be beneficial. I recommend people take it at bedtime because it can make you sleepy, but it might also help improve sleep quality for some folks. There's an intrauterine device that has levonorgestrel, and of all of the forms that have it, it's specifically the highest strength one, the Mirena, that's been recommended for use for endometrial protection when using estrogen menopausal hormone therapy. And that's if you're changing it every 5 years, which is confusing because the Mirena for contraception has been approved for up to 8 years now. So you want to change it a little more often if you're using it as part of your menopausal hormone therapy. There are other forms like medroxyprogesterone acetate, which we see most often in the injection, Depo-Provera, but it also comes in a lower strength in a pill form, and norethindrone, and it continues. There are more. Here's what I wish I had known 15 years ago. I could have helped a lot more patients if I knew that we can start hormone therapy in perimenopause. You don't have to wait for your final menstrual period. The doses of estrogen are not high enough to interrupt whatever ovarian activity you're going to have. It's really different than contraceptive level of estrogen, which does interrupt your ovarian hormone cycle. So you're not going to mask that starting before age 60, but you can treat the periods of low hormone where you're feeling symptomatic. So it's recommended not to start menopausal hormone therapy after age 60 or more than 10 years after your final menstrual period. And that's got to do mainly with the studies like the WHI showing that there does seem to be a higher risk of heart attack and stroke if you wait longer or you're older and then you start. Does that mean you absolutely cannot start a patient on it after 60? No. That's another one of those one-on-one conversations you have with your care provider and talk about the risks and other things a person can do to lower their chances of heart attack and stroke, and then come up with the decision that fits you. And this is talking about systemic hormone therapy or whole body hormone therapy, like estrogen by mouth or through the skin. When it comes to vaginal hormone therapy, there is no sort of age limit. or period at which it's unsafe to begin. And we also don't have a 5-year limit anymore on hormone therapy. This is a nice change in what we know compared to what we thought we knew when I started practice. You can continue hormone therapy as long as your patient wishes, unless something else has come up that makes it not recommended. Like if you develop an estrogen sensitive cancer, like breast cancer, then it's best to avoid estrogen unless it's a specific type of selective estrogen. Or if you have like a deep vein clot, like in your leg vein or in your lung. So you can start early. You can continue as long as you and your care provider agree that the benefits outweigh the risks. And there's a very small increase in risk with estrogen and progesterone. It depends on if you're taking the progesterone continuously or if it's only 2 weeks a month or cyclical progesterone. And it also depends on the kind of progesterone you're using. If you start your hormone therapy younger, it seems like there's less of an increase in breast cancer risk with hormone therapy. And estrogen alone doesn't cause an increased risk in breast cancer. And for context, the risk of breast cancer is higher for those of us who have a higher body mass index or for those who consume 2 or more units of alcohol a day. And having dense breasts increases breast cancer risk by 6 times. So there's lots of other things that can affect breast cancer risk, some of which we have the ability to make changes to, some of which we can't. But wouldn't see the risk of breast cancer as a contraindication unless it is for you, right? Depending on your family history and what your friends have experienced. If you prefer not to go on hormone therapy with estrogen, that's just fine. We do have other options for you. There's a lot more than medications, and Robin mentioned this also. So lifestyle measures, this is as universal as everything in medicine. Motherhood and apple pie are good for you. Exercise, a healthy diet high in fiber and protein and low in saturated fat and processed foods, a good sleep routine, getting up at the right time every day, and reduction in substance use or avoiding use of things like tobacco, nicotine, alcohol. Cognitive behavior therapy is often the right answer on med school exams. It helps a lot of things in perimenopause and menopause as well. It can help reduce severity of hot flush symptoms. It can help address mood changes and disturbances with sleep. There's a special kind called CBTI specifically for insomnia. It can help with weight management, etc., etc., etc. Hypnotherapy, can you believe it? Can help with hot flushes, done with a specific type of hypnosis provider, apparently. Pelvic floor physiotherapy, I can't say enough good things about this. If you have the ability to access pelvic floor physio, it can be tremendously helpful for genitourinary symptoms, in particular bladder retraining, for urge incontinence, if you're having issues with pelvic floor prolapse. It goes on. Sex therapy can be helpful for any issues with sexual function. I wish I had more to say about that. I know there's lots of psychologists and social workers around the province who do provide sex therapy. As far as I know, it's all private. So one of those things that ought to be covered in healthcare and just isn't yet. I'm supposed to be thinking about something on this slide and I forget what it is. For those,
Might be sex therapy.
it might be sex therapy. Yeah. And how I wish everyone could have that and universal drug coverage, because that'd be awesome. For those who can't or don't wish to take estrogen for any reason, we have something called fezolinetant, which acts on hot flushes and maybe night sweats. So there's a non-hormonal medication that's quite effective. There are a number of antidepressant meds and a few other, some of them are seizure drugs, that have been somewhat helpful for many people with hot flush symptoms. None of them are as effective as estrogen, so that's still first line for those who can and want to take it. But we are getting new agents brought forward that can be worth a conversation with your doc. Back to my favorite part. These symptoms that just will continue for the rest of our lives and can be really disruptive to function. And we kind of went over what they are already, so I'm going to skip through that slide quick. It just doesn't get better with time. Where the hot flushes for many people do, this one doesn't. We don't call it atrophy anymore, thanks. Although my handout, which I printed from the Canadian Menopause Society, you can tell it's a few years old because it still talks about vaginal atrophy. So I crossed it out, and in my very neat printing, I wrote genitourinary syndrome of menopause. Visible changes can happen. Changes that you can feel with your hand can happen. Shrinkage of the tissue, reduction in size of the labia minora, pale tissue, loss of folds on the inside of the vagina. It's really can be quite traumatic. Local hormone therapy is really safe and really effective. It's the equivalent, Dr. Cluett taught me this. If you took one oral contraceptive pill and broke it into 104 pieces and took one piece twice a week for a year, that's the same amount you get absorbed from taking a year's worth of vaginal estrogen. There's no association with breast cancer risk, heart attack and stroke risk of blood clots. You will get more discharge. That's one of the ways it affects the tissue. But beyond that, unless you're allergic to one of the ingredients in the product you're using, it's very safe. Not to be started if you're having unexplained bleeding, especially if you're having bleeding more than a year after your final menstrual period. That always needs to go to a doctor or nurse practitioner and get investigated. But beyond that, vaginal estrogen can be used safely in almost everyone. The product names can be pretty terrible. I don't know anything worse than Vagifem, especially for my young trans guys in particular, but it can be a game changer as far as symptom management. And we're getting newer forms all the time. So there's tablets that you insert, or there's a little ovule, or there's a cream, or when it's available, the ring, which is handy if you're only needing to put it in and change it every 3 months. Not handy if it keeps going on back order though. It isn't magic, it's medicine, although it can feel like magic after up to 3 months to get the maximum amount of change, especially if it's been a while since you started having your menopausal transition. So be patient with it is what I advise my patients. It can help with urgency incontinence where not much else other than bladder retraining can. And it can really eliminate a lot of the discomfort around genitourinary syndrome of menopause. And talk about lowering rates of bladder infections or bacterial vaginosis. It's pretty handy. Non-hormonal options. I know I'm over my time. We have this pill now called ospemifene. It's a pill you take by mouth. That's to treat genitourinary symptoms. There's also, it's called Intrarosa. It's fatty acids that the body converts into tiny amounts of estrogen and testosterone. That's inserted daily into the vagina. Those both require a prescription. And then lubrication for penetrative activities, or a moisturizer like a lotion that you use 2 or 3 times a week. And something I just learned is that the osmolality of the products you use vaginally really matters. And so the World Health Organization recommends they be below 380 osmolality. And a lot of the products we used to use, like KY jelly, is something like 2,000. And that's just going to cause drying out of the tissue. Oh, there it is. I wrote it down. Replens. I used to advise people to use Replens moisturizers all the time, but it likewise is a very high osmolality. If you have access to the internet, you just type, what's the osmolality of Replens, and it'll pop it up right away. I also learned that when you're using the skin cream for your menopausal hormone therapy, you have to put it on in the same place. Every day in the same place. It absorbs best if you keep putting it on the same area, And you want to use an area where there's some fat beneath the skin. I used to tell people to switch it up all the time so that they avoided skin irritation. Turns out, that's what the package says to do. Okay, this is the end of my presentation. Thank you for your patience.